Okay, we go to induction agents. Any questions for us so far? No, pharmacology and make you yawn. Yeah, unless you sit down there and then you start reading and start drawing graphs and start analyzing the SAR, then you will understand what it is. Okay? Alright. So the general objective is very simple for each of these four drugs. Actually, you just have to know the pharmacology of each of the drugs and be able to compare the differences between them and know what is the clinical significance. It's basically like you're running a case. Why you want to give propofol, why you want to give etomidate. You have to justify it based on your PKPD knowledge. Okay. So what is IV anesthetic agents? This is the question for the houseman, so I can answer for you. Agents that will induce loss of consciousness in one arm brain circulation time. So these are what is the ideal property of an IV induction agent? These are the things that I think won't cover in MCQ because of rush, very long list of it. But for you to write in SAQ later on is important. So we divide into three. We want to classify our answers. So it's the physical chemical properties, the PK properties, and also the PD properties. Okay. Then we'll go through it one by one like this. So draw your own table and know what is the favorable properties of each of these. Okay. Get the drugs over here and you have to include dexmedetomidine, midazolam, and that. Okay. So for IV induction agents, you cannot skip lah. I think for MEDEX, you need to know all these drugs, inclusive of dexmedetomidine and midazolam, because all these drugs are relevant. So classifications, very simple. Barbiturates, non-barbiturates, and barbiturates is your thiopentone. So formulation and SAR, again, it comes to SAR, nobody likes SAR, and people say SAR won't come out anymore. But knowing the SAR will actually make you, how do I say, it actually make you know the drugs better, you remember them better, and understand why it is so and how it be. Okay? So thiopentone, you need to know the formulations, you need to know a little bit of this, and you know that it's a racemic mixture, it's a stereoisomers. That's why I say it's important because they still can ask you questions like which of the following are isomers. Okay? So thiopentone, yes. Right, this is the content. You are expected to be able to describe things like that in your exam, not MEDEX, again, it's in your primary exam. And inclusive of this. So what is this 2.5% solution benefits? The preparation is actually in a very high concentration to dilute it into 20 cc, isn't it? Right, so make it painless and then but it still causes tissue irritation if extra oxidated because of the very low, very high pH, very alkaline. So the SAR, if you don't remember, very simple, you just have to remember the position 1 and position 2. Position 1 is over here, position 2 is over here. Position 1 is either replaced by a hydrogen or a methyl group, and position 2 either by an oxygen or a sulfur group. Okay, then you focus on these barbiturates, thiobarbiturate, which is a thiopentone. So for thiopentone, we have sulfur group in position 2 and hydrogen in position 1. So making it 1 hydrogen, make it have this very rapid onset, and sulfur give you the hypnotic effects. Okay, so the same thing over here. Thiobarbiturates, we've got this H and the S, so make it very rapid acting and also rapid acting, so smooth onset and rapid offset, and also it has got analgesic effect. Right. Anybody can identify this structure? You are using this drug every day. Propofol, yes. Can you name this structure? Dimethyl phenol. Okay, so this is a phenol group. This is the methyl group. It has got 2 of them binding to each of these. Okay. Alright, so preparation of propofol, you need to know at least there's 1, 2, and 3. There's soybean emulsion, non-lipid formulation, aqueous solutions. When you come to your MCAI, OSCE, and when you come for your part 1 exam, you need to be able to describe all these things. 2.25% of cholesterol, by the time you exam, you'll be able to just blur it out. Okay. Okay. Again, this type of thing, it has got another formulation which has its MCT and LCT. Adding in the MCT will make it less painful because it's more soluble on injections. Okay, some preservations, disodium, either EDTA, the sodium metal bisulfate, and benzyl alcohol. And what happened? What are the problems with all these preservatives? And the current preparations actually have few of preservatives. That's why you have to discard them after 6 hours. Okay, etomidate. It's carboxylated imidazole derivatives. There's 2 isomers, the R and the E. Okay, do you know that this actually has an isomer, etomidate? Anybody got etomidate in the hospital? Okay, but etomidate you need to know, okay, for your MEDEX. Alright. So this imidazole ring is what renders it water soluble. You need to know this imidazole ring because you're going to do midazolam later, and you're going to have this word again, imidazole. Alright? You need to know the formulations. Again, there's 1, 2, and 3. Okay. Not important for MEDEX, so I'm skipping it. Okay. So it's a crystalline compound, it's the midazolam, it is soluble in the hydrochloride salt. So its preparation is actually in the acidic environment. Okay. To talk about the water solubility of midazolam, you know what's so special about this midazolam among all the other benzodiazepines? It's because it is water soluble. The other benzodiazepines, they are more lipid soluble, that's why they are very painful on injections. Okay, that's why you don't need diazepam for injection, it's very painful. Okay, midazolam is less painful because it is soluble in water. What renders the solubility is this imidazole ring. Okay, it's an imidazole ring. That's another mechanism which is this the Wagnerian ring opening phenomenon. We have this diazepine ring as well, which is over here. Okay, this is the imidazole. Sorry, this is the diazepine ring. This is the imidazole ring. So for this phenomenon, they say that it can also open up and then making it very water soluble at the pH of less than 4. However, at physiological pH is approaching 0. That's why it's almost contributing to none of the water solubility. But however, imidazole ring is what renders the midazolam water soluble. I hope I'm not confusing you with all these terms, but you know that midazolam is a 2 ring, which is diazepine ring, and the imidazole ring, and the imidazole ring is the one that contributes to the water solubility. Okay, next, ketamine. We are only at the pharmacokinetics. Okay, ketamine is a basic compound dissolved in acidic solutions. It has got these two things is important. S-ketamine, the R-ketamine again is an enantiomers. Okay, it's an enantiomers, you have S and R. And what is the good one? Which is the good one? S or R? S. Okay. It used to be a very famous question in our entrance exam. Which one is a better one, S or R? Okay. So S is the good one. And then we don't have the S ketamine preparations, but if there is, actually it's safe for administrations epidurally as well. Okay, and S as compared to R, it has got 4 times more potent, right? It acts on the NMDA receptor still, and then it's a very fast clearance, short duration of action. It does not have these psychomimetic effects and emergence delirium. So at the end of the day, at the end of the day, you need to have a summary of this table as well. Which tell you the mechanism of action. It always asks in primary exam as well. Okay, describes the mechanism of actions of IV inductive agents that you commonly use in anesthesia practice. Example like that. So you need to describe GABA receptors, glycine receptors, and then NMDA receptors, the neuronal acetylcholine receptors, and on top of this, dexmedetomidine has been used very broadly nowadays. Alpha-1 adrenal receptor. Okay, you need to know the receptors and be able to describe them. And it can come out in MEDEX, yes. Because the GABA subunits, they can ask you, is it true or not? When GABA is actually a heteropentamers that consists of 2 alpha, 2 beta, 1 gamma. Okay, so you need to know 2 alpha, 2 beta, 1 gamma. And then primarily, we used to ask these questions where is the sub actions of your benzodiazepines and your propofol. Is it alpha, beta, or is it alpha, gamma? So draw this picture yourself, okay, and then label them and plot this ... Okay. Alright, then we need to know what is the effect when the drug acts on the GABA receptors, and then it depends on these subunits and things like that. I think you need to know for MEDEX for now. Okay, the other receptors, which is the glycine receptors. The other receptors you need to know as detailed as the GABA receptor is your NMDA receptors. Okay, you need to know this picture with all these small molecules. Looking here, zinc, we have got this galamine, and then we have got this magnesium over here. This is one of the famous questions they ask you, how to activate the NMDA receptors. You need to take this magnesium out so that the receptors can work by the excitatory effects. So we block these receptors, you don't get the excitation. Alright, we talk about all the physical chemical properties of your induction agents. Now we go into the pharmacokinetics of the thiopentones, and then we go into the other drugs as well. So administrations can be IV, it can be rectal. Distributions, you need to memorize for MEDEX, even for primary exam, I think they already asked you because there's so many other questions they can ask you already. Nobody really remember all this protein binding, but at least you need to know something like, which drugs has higher protein binding as compared to the other. Alright, so you know the BD. Why you need to know that is because when they like to ask questions which are more clinical applied nowadays, meaning that they'll ask you in pediatric patients, for example, in elderly patients, in patients with liver disease, what will be the changes in the PK and BD? You will know that, okay, in these conditions, there's increase in BD, so a drug with high BD require a higher dose. Example, okay. So, anybody knows these terms, automerization? No, Anybody doesn't know what is automerization? Okay, tautomerization basically is the change of one of the proton units to the other side, of this molecule. But it does not change the empirical formula. It means the overall formula is the same, and does not change the charge. But it actually make it ionized, make it soluble or not soluble. Okay. Alright, that's tautomerization. Basically just change the proton group. You change the proton group, but it does not change the total or empirical formula. Okay, distributions. When we talk about thiopentone, specifically distributions, we use these three terms: vessel-rich group, master group, vessel-poor group. Okay, don't confuse yourself with the pharmacokinetics lectures or whatever you have gone through. They always use first compartment, second compartment, third compartment, kind of thing, right? Okay, this one specifically for thiopentone, we use vessel-rich group, master group, and vessel-poor group is different. Okay, so when we read about thiopentone, this is what we use to describe how it's going to be distributed from 1, 2 to 3. Okay? I give you a very broad overview of what you're going to be expecting. Alright? I have a problem when I sit for my primary exams because we don't have all these things. Right? Nobody tell me that you need to know and what is the differences and how you're going to describe. That's why I'm telling you this. It sounds a bit boring, but at least you heard it before, so the next time when you come across with it, it's more familiar to you. It's not something that's very foreign. Okay? Then PK, ADEM, so we finish with administration. We talk about the distribution, so we go to metabolism and eliminations. So relative long terminal elimination, half-life very long. So for those patients on this barbiturate, thiopentone coma, because on the CR and things like that, you expect them to actually wake up very, very late later on, and it's got very, very large PK. So the metabolism, if you don't know, it's okay, but it's actually liver metabolism. So it's metabolized to this and this. Just read about this. Okay. So at the end of your PK, when you read about each of the drugs, again, you just have to remember what happens when there is an altered PK. So altered PK in your exams, in general, you need to know a few populations which is special. Pediatric, obstetric, okay, elderly patients, patients with liver disease, patients with kidney disease. Okay, and one more, obesity. Okay, if you can describe how you're going to use the drugs in these special populations by explaining using your PK knowledge, then you know about the drugs already. You can skip and go to the next one. Alright? Okay, every slide will have, every drug at the end will just go by this one. So you need to know about the BD. You can talk a bit like SAQ, but when it comes to MCQ, normally they will ask you this question because it's actually quite controversial in some of the cases. Okay. Next, we go to propofol. Okay, administrations only by IV. There's no more rectal oral. It's not going to work. Okay, distributions. Because of this, because it's a weak acid with a pK of 11, 99% is in the unionized form, make it very lipid soluble. So action is very, very, very fast. Okay, the KEO is 0.24 minutes. Okay, and then high protein binding 98% with distribution half-life of 2.6. Whether you ask me whether you need to know all this or not for MEDEX, I will say no. Okay, no. But if you are reading, then you're preparing for part 1 for MCI. Just read and remember them, okay? Because it takes at least 5 to 6 times before you can really remember this figure. Metabolism eliminations, almost entirely is metabolized and metabolized by the liver, again, or by the liver, okay? So, need to know these recommendations to this propofol propionate, also by recommendations, and this is by the sulfations which are oxidative pathway. So I told you just now, we talk about opiates, we talk about TIVA. We talk about induction agents, IV, we also talk about TIVA. We need to know context-sensitive heart time. Very simple thing, okay? You understand what is context-sensitive heart time, then you understand it's the time taken for the plasma concentration to drop by half after the cessation of the infusion. So drugs that will accumulate, will have a higher CHT. The longer you induce, then it take longer time for it to come down. Common sense. And drugs that is not affected, example, remifentanil is a very good drug. No matter how far you give, it's still the same. So you need to know this figure. It can come out in MEDEX. 11 minutes for an hour of infusion, and added to that 4 minutes for each additional hour. This one you need to know. All right? When it comes to CHT. So again, see, pediatric age group, what do? Higher VD. So it has a very high VD, high lipid solubility. So you are expecting to give a higher dose. Okay? And maintenance as well. And rapid recovery even after prolonged infusions. For geriatrics, because of increased sensitivity and smaller VD, you need to give a smaller dose. Hepatic dysfunctions. Hepatic dysfunctions, they have a large VD, so but unchanged clearance, so slight prolonged and initial half-life, give a infusion dose. And then renal dysfunctions, PK unaltered, cardiac dysfunction, of course, you will give very slow, right? So sometimes you just have to use some common sense by saying if you don't read, the brain doesn't know what I mean. The brain, I haven't seen what the brain doesn't know. Okay. And to cover on your own, all these things, etomidate, ketamine, midazolam, dexamethasone. Okay. The same thing you're going to do, you go through the PK of the drugs, you know the preparations, you talk about the lipid solubility and comparisons. In comparison, you cannot remember figures. But PK is good to remember because PK only one figure for each of the drugs. Okay. Knowing the PKA, then you'll be able to identify some of the drugs which are soluble or not soluble. So you know the preparations really. And then you know what happens with the symptoms. Okay. This is a summary of it. So if you can remember, not the half-life, I think you won't be able to remember. I myself don't remember, but at least you know 98% of protein binding for propofol, 98%, high protein binding. So you can get a bit of right? Pharmacodynamics of IV anesthetics. So again, each of the drugs you have to go through by the system and then mention and what is expected. You are expected to know in very details how detailed it is. For example, we talk about CNS. CNS, we talk about EEG changes in each of the drugs in the okay? So for example, we give thiopentone, there will be EEG changes in details. You will get a reductions, change from beta to alpha to delta, okay, followed by burst suppression at higher dose in cause isoelectricity. Okay. To this extent only, okay? Not further, not more than that. Normally they will ask you anything more than that, no time. Okay, it has got no analgesic effects. It gives you anesthesia, anticonvulsant effects, and the effects on the CMR2, CPF, and the response to the CO2 is over here. Okay, it's a good drug, so I use for cerebral resuscitations. Okay, in CBS, again, just now you go for your physio, we went for a physiology class, isn't it? So we learned about CBS system, we talk about MAP, we talk about cardiac output, we talk about pre-load, after-load contractility. So list them up over here, then list your drugs over here, and just put a minus and plus and no effect. Okay, you can do your own table for this. Everybody who sit for exam later on will have their own table, trust me. Okay, a table that you do on your own, meaning that you can close your book, draw it out. If you can draw it out and then you match, there's nothing wrong, or minimal mistake, or basically something, like this are plus minus kind of thing, no issue. Basically means that you are ready for exam. Okay? Alright. So respiratory system, go about respiratory depressions, and then respiratory system again, we talk about whether it obtain reflexes. Okay, it change the respiratory rate or not, reduce the minute ventilations or not, and any reactions to the oxygens and also the carbon dioxide sensitivity. So renal system, whatever that can reduce your blood flow will actually reduce your renal blood flow. Reduce your cardiac output will reduce your renal blood flow and so reduce your GFR as well. This one you can get along with it. And then liver, again, the same thing, hepatic blood flow will change if let's say they reduce your cardiac output. So cover on your own, not the others. I'm so sorry, no time for all these things. But this is what you need to know when it comes to PD. PD, each of the system and each of the drugs actually have their own peculiarity. For example, propofol. In the CNS, it's not only anesthetic effects, you got antitussive, anticonvulsant, antipruritus, anti-emetic. You need to mention all these things. For ketamine, CNS effect, emergence delirium. Okay, well, it causes vivid dream, and what is the definition of vivid dream? Okay, etomidate effects on the steroid suppression of unless you never used before. Okay, they come up with a table like this, which one cause histamine release and things like that, up, down, and Make your own table, not copy a table and then put in your notes. Make your own table and then you match and see whether it's correct. Okay. Again, advantages and disadvantages. Adverse effects. So again, you go by system. Adverse effects, they can ask you what is the effect and also what is the adverse effect. So effects is what we wanted just now, how the anesthetic, anesthesia, analgesic, things like that. The unwanted effect will be those impact psychomotor performance. When you give the patients, for example, the thiopentone patients will move their limbs intentionally, things like that. Impact judgment and reaction of time, PONV and CVS, talk about hypotension. In respiration, we talk about hypoventilation, cerebral spasm, allergic reactions. And special things about this, thiopentone will cause porphyria. This one is important. Intra-arterial injections always ask in exams. MEDEX can ask as well. What happens when you give thiopentone inadequately into the intra-arterial system? Okay, what are the expected reactions and how do you manage? They come to management. Midazolam, respiratory depressions, reduction in hypoxic drive. Dr. Iskandar mentioned just now what will cause hypoventilations. Okay, what will cause alveolar hypoxia? Propofol, so allergic reaction, anaphylaxis. Which of this content will, of the preparation of propofol will cause this? They cover an exam as well. Pro-convulsion activities, excitatory phenomenon, abuse potential. Okay, this one, anyone who knows who is the very famous star who abused propofol? Okay, intra-arterial injections, again, it just pain, it won't cause the effects like thiopentone leading to ischemia and thrombosis. Okay, bacterial growth, pain injection, propofol infusion syndrome. This is what you need to know also in very detail. The risk factors, the mechanism, the signs, symptoms, and also how to manage propofol infusion syndrome. Very simple, to stop it, okay, and support organs. For ketamine, emergence delirium, know about the signs, symptoms, the patient's habit, the mechanism, how it actually causes emergence delirium, the management and its prevention. Okay,